So I'm going to piss off a lot of people because here's, just like I said, there's nothing that is not there for a reason. And you can't just say, oh, as we age, NAD gets lower. If I put NAD back in, I've made that patient better. So that's what people do. They measure NAD. Whether you can actually measure NAD is very controversial. People can tell me they can measure NAD and NADH ratios. It's inside the mitochondria. Again, you really can't get a sense. It's very different. Cytoplasmic and mitochondrial levels of NAD are very different. So you really can't get much from an NAD and NADH.
Welcome back to another episode of the Smarter Not Harder podcast, your home for 1 cent solutions to $64,000 questions. I'm your host again today. My name is Dr. Scott Scher, and it's a pleasure to be back with all of you. And this episode, ladies and gentlemen, so amazing to record, Dr. Elizabeth Yurth. She's a colleague, she's a friend. Here is her bio. Co-founder and chief medical officer of Boulder Longevity Institute. So she's my neighbor. She's been providing tomorrow's medicine today to her clients since 2006. She obtained her medical degree from the University of Southern California, Keck School of Medicine. So she was my competition. I went to UCLA undergrad. She did her residency at University of California, Irvine, and her fellowship in sports and spine medicine from Stanford-affiliated Sports Orthopedics and Rehabilitation, also called SOAR in Palo Alto. She's been a 30-year practitioner of orthopedics in sports medicine and spine medicine. She's made it her mission to learn and share the latest scientific research on how to truly heal the body at the cellular level. She's fellowship trained in anti-aging, regenerative, and cellular medicine, and has completed over 500 hours of CME training focused on regenerative peptide treatments and regenerative orthopedic procedures. Some call Dr. Yurth the GOAT, the greatest of all time when it comes to longevity medicine. And there is no doubt she is one of the smartest people that I know. And this is a fantastic podcast to record. We talked about controversial things, including novel therapeutics for various types of conditions, including cardiovascular disease, arthritis, cancer, long COVID, neurologic disorders, and we dove into the controversy around NAD. She does not think NAD infusions, NAD supplement is likely a good idea, and she will talk about that in detail at the end of this podcast. We talked about various types of novel therapeutics that she has repurposed as a result of multiple different types of data, animal, human, across the world, for things like arthritis, and how she thinks that cardiovascular disease is vastly overtreated because of a lot of people out there like Peter Attia and others who are encouraging significantly decreasing our LDL and our ApoBs to ridiculous levels. And she'll tell you all about this and why. Listen up, ladies and gentlemen. This is a fantastic podcast. It's going to challenge some of the things that you think about, including maybe where your target cholesterol should be and more. If you like this podcast, please don't forget to like and subscribe below. Please share with your friends. And we can't wait until you hear this one. Enjoy. All right, Dr. Yurth, Elizabeth, how are you?
I'm great. Thanks for having me here, Scott. So happy to be here to talk to you.
You're only about 10 minutes to drive, but we're doing podcasts in different locations because I don't have a podcast in-person setup or anything like that. But I was really excited when I first got to meet you, not even that long ago, probably maybe last A4M. It's been a little while, but being involved in the longevity space, I've heard you called the GOAT a couple times. I don't know if you believe that. I don't know how you want to say, but I've been on some longevity chats with you. And the reason why I want to bring you on is because you have so much knowledge to share with clinicians and so much work that you've been doing for so many years that have been on the forefront. So thank you for being here, number one. And then let's just dive right into it. I wanted to talk about some of the novel ways you're using therapeutics in clinical practice, because again, you are on the forefront of all this. So I'm going to let you lead the direction. You can talk about individual stories of patients or just clinical pearls, whatever you think. So go ahead, start. It's on you, and then we'll go wherever we go.
So funny because you and I have gone to medical school and gone through that whole brainwashing of medical school and everything. In medical school, we learn, okay, you have this disease, you treat it with this drug, right? So you've got this disease, this is your choice of treatments. And so you have a patient that walks in with hypertension. Okay, I'm going to start, this is your protocol. You start with an ACE inhibitor, or you start with a diuretic, or whatever it might be. And then you move to yours. And there's not a lot of thought process to why you choose one drug over another, right? There's some little thought going to it more. it's a little bit of, okay, this is what you start with, and then you go this, and then you go this, and then you go this. So everything's protocoled out for us. And if you think about medical school, very little of medical school relies on actually understanding and learning. Mostly it's memorization and learning protocols. And we used to laugh. As one good friend of mine in medical school, he was a guy who would not settle for just memorizing things. He had to like perfectly understand everything. It would take him so long to get this stuff. Just memorize it. It is what it is. It is what it is. No, you got to understand this stuff. And now I've gotten to back with him in this protocols. It's like if you really want to treat patients, it really comes down to understanding the disease and the mechanism of every one of these drugs that we're using, right? So if I truly understand what pathways go awry in a disease, is there a certain mitochondrial, a certain place in the mitochondria that are dysfunctional, or a certain receptor that's affected, or a certain pathway that metabolically becomes either disactivated or activated, then I can find a drug. And if I know the mechanism of that drug, and it may well be, it could be a peptide, it could be a supplement, but it could be a drug that's widely available to us, that's FDA approved and nothing that anybody frowns upon. And I could say, okay, this drug does this. I can use it for this disease. So when I treat these patients, that's where I'm coming from. My more complex patients particularly, right? If they come in and they've got this complex disease, I'm going to pick apart what pathways, and sometimes it's multiple, right? What pathways are disrupted. And now I can go, okay, I know a drug that affects that pathway. And if I use that drug, I'm going to affect this pathway. So if I have a disease, there may be 3 pathways that are paramount to fixing that disease. I can find 3 drugs that work on this pathway. So that's really the way I think. I think it's a lot different. And you and I were both just at Peptide World Congress. And one of the things that William Seitz, who started that whole organization, really emphasizes is that people want protocols. When you give lectures, everybody wants, what's the protocol? Like when you're talking about your HBOT or your methylene blue, what is the protocol for this? Yep. And you're like, that's not really a protocol, right? You're going to decide on what to do based on how that patient's presenting, what exactly is wrong with that patient. But people want protocols. Doctors just want protocols. And we're trying to educate out of that mindset and into a learning mindset to understand diseases and to understand mechanisms. And when you do that, you can do so much for patients. So that's the way I approach things, which is a little different than your protocoled approach, right?
Totally. Yeah. So many doctors now, that's what they're looking for. They have protocols that are available to them, and it could be a great jumping off point for sure.
It could be helpful to say, okay, but to never learn why you're doing that protocol it's going to help you with some patients. It still will. If you give a standard HBOT protocol for a wound healing or whatever, it's going to help. But if that patient's not getting better, there's the now what? Why didn't that work? And now what? So let's say somebody comes into and we'll take arthritis because it's one of my specialty areas, right? So somebody comes into my clinic with arthritis, and my background, for those of you who don't know anything about me, is orthopedics. So I was in orthopedics for a long time and really started getting into this type of medicine about 18, 19 years ago now, when I really got frustrated with, I don't ever seem to actually get people better. I would patch them together, but they were never all better. And they come in with something else falling apart and something else apart. And finally you replace their knee and then you replace their hip. So I started exploring how can we actually look at these even arthritises differently. And what I started to learn is that arthritis, just like every other degenerative disease, is a disease process. People think of arthritis as you wear yourself out. I ran too hard. Or I was a football player, so of course I blew out my knee and I had all these problems. Honestly, that's not the case. If you look at the people who have the most degenerative joints, it's the more sedentary people. So it's really not activity. You can certainly create inflammation by injury, and that can accentuate the process or hasten the process. But ultimately, it still is an inflammatory disease process. I have a lot of football players in my practice that are fine, right? They're 60-year-old now and are fine. Then I have 40-year-old football players or 30-year-old football players that are a mess. So what was the difference between those people? So then you go back to looking at the pathways that are affected in arthritis. And when you look at arthritis, we know that there's a very big elevation of one of the cytokines called interleukin-1 beta. So I always think about rheumatoid arthritis. Rheumatoid arthritis is considered inflammatory. Osteoarthritis, not an inflammatory arthritis. It's actually not true. They're both inflammatory arthritises. They're just affecting different cytokines. So as rheumatoid arthritis, you'll see elevations of tumor necrosis factor alpha and interleukin-6. In osteoarthritis, you see much bigger elevations of things like interleukin-1 beta, downregulation of interleukin-10, and you see very high levels of abnormal proteins and abnormal enzymes. So you see very high levels metallomatrix proteases and of some of the pathways that are more destructive to cartilage. So when we're looking at treatments for these diseases, we can't just say, okay, I'm going to go stick steroids in there, I'm going to scope the joint, I'm going to do rehab. We have to actually treat the underlying inflammatory process. So if you came to me with a torn meniscus in your knee, the first thing I'm going to do is stop your body from destroying the cartilage. So you come to me, your knee's still hurting, you have a torn meniscus, you went to your orthopedic surgeon, they're like, let's scope that, we'll clean it up. Okay, what does that do? If I go clean up that knee, clean up, meaning trimming out the cartilage, which doesn't make a whole lot of sense when you think about it, right? So you trim out this torn cartilage, and now I've created more inflammatory processes. Okay, so I've upregulated these degradative enzymes, so they're turned on. I've upregulated these inflammatory cytokines, so they're all turned on. I've upregulated things like neural growth factors that cause more pain at the joint. And everything actually cascades and gets worse, which is why when you do something like scope a knee, you hasten the arthritic process. Right. 80% of people who have an scope of their knee will end up with further degradation down the road. They may temporarily feel better. So there is a temporary benefit perhaps to actually taking out some of the pieces of torn meniscus. It's very temporary. In fact, that procedure has been banned in every other country. You cannot do a meniscectomy. It is not allowed in any other country because it is such a bad surgery. And it's our bread and butter in orthopedics. So you come in here, what I'm going to do is say, we got to get your inflammation under control. Now, if you're in a lot of pain, what I might do is aspirate the fluid off the joint and put some platelets or exosomes into there. So I might do something that actually reduces inflammation first and helps with healing. But we're also hand in hand going to put you on something like a drug called pentasin polysulfate, which you've heard me talk about probably. Pentasin polysulfate is an approved drug for bladder inflammation. But if you look at its mechanisms, it is the perfect drug for treating osteoarthritis. Basically, it reduces interleukin-1 beta. There's not a lot of drugs that go after the interleukin-1 beta, so it reduces interleukin-1 beta. It reduces the inflammatory degradative enzymes that are upregulated. You can upregulate or downregulate the things that are eating away at the rest of the cartilage. By blocking those, I've stopped the degradation. I've reduced the inflammation. Now I've put in things in there that will help you heal, and you can heal that joint, right? Basically, again, thinking back to the mechanisms of that disease, I'm going to treat it very differently than this is just you went out and tore your cartilage. So that would be one example, right, is using osteoarthritis, which is never considered a disease process. It's considered, oh, bad luck, you tore your knee cartilage, blah, 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 you overused your knee. One of my old partners in my orthopedic practice used to always say, oh, your hip arthritis is just a sign of a life well lived. You just got to do a whole lot of stuff and now you're paying for it. And that's bullshit. When you look at osteoarthritis, if you have osteoarthritis in your joint, your likelihood of having a cardiac event is tenfold higher than somebody who doesn't have osteoarthritis, independent of the fact that you may be exercising less, even if you exercise at the same level. So we know
what do you
the
think
reason for that is because the same inflammatory cytokines, the same processes are involved, right? The same processes are involved in cardiac disease as are involved in sort of degenerative joint disease. High levels of interleukin-1 beta in cardiac disease, high levels of some of the inflammatory degradative enzymes in cardiac disease. So we know that we basically are treating a disease process, and yet we ignore that in the whole orthopedic world. Again, that's one place, and I'll do that with every disease. Osteoarthritis is an easy one because it's thought of differently. But same thing's going to be true if you come with an autoimmune disease. We're going to do the same thing. We're going to say, what disease do you have? What is your autoimmune disease? What pathways are most likely disrupted in you? Because there's a lot of different pathways that can affect autoimmune disease. And now I've got a choice of drugs that I can go after, depending on that pathway.
So this drug that you were mentioning, the bladder drug, for example, how did you find out about this? Was it something you just went through the pathways and figured it out? I think this is a drug that's been a long time, right?
Pentasin polysulfate has been around since 1984. It was approved as a drug, Elmiron, for bladder inflammation. But it actually started there's a company called Paradigm Pharmaceuticals out of Australia that actually works with repurposing drugs. So that's the whole drug company. They repurpose already available drugs. Great gig, because it's much easier to take a drug and repurpose it than try and develop a whole new drug. So in about 2017, Paradigm started looking at pentasin polysulfate. So they looked at the mechanism. and said, "Ooh, this would be good for osteoarthritis." So basically, they started marketing or started experimenting with this drug, repurposed for osteoarthritis, and they started doing it in all their football.
Pardon the interruption. This episode is brought to you by Health Optimization Medicine and Practice Association, a nonprofit organization training practitioners how to optimize health rather than treat disease. Check out the gut immune system module. Gut optimization is so important for our patients. If they have leaky guts, they have leaky brains, they don't feel good. Everything starts and ends with gut, full stop. Check out homehope.org and save 10% on this module by using code podcast10 at checkout. Now back to the show.
Ball players, all their soccer players, football players, and their rugby players. And particularly in the rugby, because it was a huge problem for these guys that had a lot of osteoarthritis. And started experimenting with this drug, found out, and they retermed the drug xylitol, so they gave it a new name. And xylitol is injectable penicillin polysulfate. So what they found was that injected, instead of taking orally, it had much better effects for joints than it did orally. And for orally, it was great for bladder. But the other positive was you could use it at a very low dose, oral or injectable. They started looking at this drug xylitol. Started being utilized in Australia for osteoarthritis. Actually reversed the need for joint replacements by almost 80% in that country. So a few years, dramatic reduction in the need for joint replacements. Basically, how did I stumble across this? One of the things I love to do, when you're looking at, is go look at research that people are doing. So you go into patents that are being filed and things like that, and you can find these people who are experimenting with these things. Then that sort of turns your head to go, oh, that's interesting. I'm going to go look at that. So I spent a lot of time just like searching what are people actually researching, right? Because it takes a long time for things to get from the research world to our world. So if you can bridge that gap, then you're way ahead of the game. So when they started looking at this drug, I stumbled across it from basically being somebody turning in a research application for this drug as the drug xylitol. And I said, oh, that's pretty cool. Started looking at it, started looking at the pathways that were affected by it. And because it was already a utilized drug here in the US, we already have it. It's Elmeron. It's widely available. It's FDA approved. We could basically just take that drug, have a compounding pharmacist turn it into an injectable for us. Exactly what they're doing. And it had already gone through safety trials and everything in Australia, and we could utilize it here. So we bridged that gap. We started utilizing this drug back in 2019. I've been on it for 4 or 5 years because I have horrible knee arthritis. I've torn my ACLs 4 times and then tore them again, didn't get them fixed. Horrible knee arthritis, to the point where everything I did was uncomfortable. I mean, I could do stuff. I skied with my braces on. I hiked, but it was uncomfortable. Everything hurt. To the point now, I've been on this drug for 4 years. I have zero pain in my knees.
What's the dosing regimen? And what's the safety profile and dosing regimen typically for like you've been using?
The safety profile is huge. The only thing that the drug Elmeron orally, just about 3 years ago, there was some people who discovered it was at high doses. So this is a 500 milligram dose orally at high doses over a 15-year period. When people reached a certain cumulative dose, I don't know why my color keeps changing. When people reached a certain cumulative dose, they're starting to develop this weird retinopathy. And so that seemed to be definitely related to the Elmeron, to the penicillin polysulfate. So dose dependent, it did cause a retinopathy that was severe and irreversible. So the drug Elmeron actually has lawsuits against it. It's still a very valuable drug, still widely used in other countries, a little less so here because of the lawsuits. But that was when people got up to a very high dose of this drug. We can use, so that orally 500 milligrams, we can use a tenth of that dose injectable. It would take 80 years to ever reach the dose-dependent response that you would develop retinopathy. So a really long time, if indeed it even causes that, because it appears that taken as an injectable, it doesn't actually have the same first-pass metabolism and may not even be linked to that effect. Actually, it's looking at animal studies, it appears not to. But even if it did, we'd have to be on this drug an awful long time. Otherwise, very low. Yeah. This is a really well-tolerated drug. The only thing I will see with people, and usually dose at about 125 milligrams twice a week, so 250 milligrams a week. The only thing is it's a thick injection. And so some people will get a little reaction, a site reaction to it. It's also a weak blood thinner. So about the same as a baby aspirin a day. which has benefits. It's actually one of
Okay.
its probably positive effects is actually as a blood thinner has some
Sure.
positive effects as an antifibrinolytic. But that's its really only side effects. And again, we've been using this drug a long time. It is now in phase 4 trials here in the US. It will come to market for osteoarthritis probably in about 2 years. But we've had people on it now for
Does that mean that
5 years. The follow-up data on this drug, so basically Paradigm just put out all their follow-up data after a year of data here in the US. Not only was pain improved dramatically in people, but 30% improvement, almost 30% improvement in joint space and in bone edema. So when
Wow.
you look at osteoarthritis, one of the things that causes pain is the load to the bone. You start to get that swelling in the bone. You'll see it on the MRI scans, those big white spots, right? So that, and people have always said there's nothing you can do for that. And once it's there, short joint replacement is not going to fix it. This actually fixes that. You will see on MRI scan imaging all that bony edema clear up over about a year. We have people on it. What they say is 12 weeks, you'll start to see improvement. What I find is, yes, for a lot of people, some people need it longer. And that it appears the longer you're on it, the better you get. Some people you can titrate off and on it. You can take them off it for a while, go back on. Some people you seem to be able to take it off and they do fine for a long time. Personally, in my use, I can be off this drug for a little while, but I start to get a little bit like more ache back in my joints if I'm not on it. So probably I'm somebody who genetically just has this higher interleukin-1 beta. I have to control it somehow. This is a good drug. But when you look at its other benefits, again, looking at pathways, now we know it has all these other benefits because of the pathways that are
That's what I was going to ask.
Anti-cancer, anti-atherosclerotic, very good antiviral, better than almost any antiviral you can pick out, and much lower side effect as an antiviral. Really good for kidney function for your patients who have kidney disease, really good for kidney function. We've now dosed it at a very low dose, so we can get at a compounding pharmacy at 25 milligram dose because you probably don't need the high 500 milligram dose that you need to go through the bladder when you're treating other things. So we dose it at 25 milligram dose, and I'll use that for my cancer patients. I will use it for GI because it's a really good prebiotic in patients. I'll use it as an antiviral hand in hand with some other things. Lots of times I'll have somebody maybe on Valtrex and that. So again, when you look at the mechanism of this drug, lower safety profile than most drugs that we're using and really beneficial on a lot of realms. It does not appear to work as well orally for joints. So I will sometimes use both. I'll have people on both an oral and an injectable form of it.
So the oral form, do you reserve that only for specific reasons and mostly use the injectable, or?
Not using the oral a lot. So the oral, because the injectable is more of a hassle, right? So I use the injectable only for osteoarthritis. And if I have somebody who has any of the other diseases, I'll use a 25 milligram oral dose. Your GI people, really helpful for GI. And I'll use it in my prostate cancer patients. There's been some good data there. So I'll put them on a preventative dose of penicillin polysulfate. I will use it a lot in my kidney people who have mild kidney, chronic kidney disease. Works really well there as well. So most of my systemic diseases, I'm going to use the oral. My osteoarthritis patients, I'm going to use the injectable. And that's where I'll tie in both. If somebody has both, I'll use both.
Do we understand the anti-cancer mechanisms associated, or is it more inflammatory related? Or we don't know?
When you look at the anti-cancer benefits of this drug, it probably had to do with its action as a heparin binding growth factor inhibitor. So it limits the availability of growth factor, and that inhibits tumor progression. But there also may be a lot with the metal matrix proteases, the serine proteases, the heparinases. Those are all blocked by penicillin. And those also probably have a role in metastasis of cancers. But it appears to be its heparin binding growth factor effects seem to be the primary effect. In some studies, it inhibits some cancers like prostate as much as 84% inhibited cancer growth in at least in vitro studies. And it's one of those drugs where why not a little bit, right? Why shouldn't I have somebody on 25 milligrams of this drug?
Especially if the safety profile is so good. And so you were mentioning, to shift over, we can talk about this drug, but other aspects on cardiovascular disease. Obviously, this is like the biggest killer in the United States. Most people die of a cardiovascular event. We have a discussion group that you and I are part of, Longevity Docs, and I've just been amazed at some of these newer ways of approaching cardiac health and lipidology. What do you think are some of the more novel things that you're doing now in practice with patients with cardiac disease? Obviously, we're talking about this particular drug and its mechanism sound like these patients would be on it, but there's a lot of emphasis on various realms of getting people's LDLs to 20 across the board. and if that's the way to do it, or we should just focus on the inflammatory side of things, and that's the most important. Like, where do you fall in this world, and kind of what are some of the novel things that you're doing?
So this is an inflammatory disease. We know very well that if you look at longevity, people who have higher cholesterols have bigger brains, they have less dementia, they live longer, right? Now, apolipoprotein B, probably the bad player. So I look, and even more, and people haven't talked about this, even our longevity docs group, Scott, people don't talk a lot about, it's actually not even just the ApoB, it's the ApoB to A ratio. So apolipoprotein B carrying it's the protein that's attaching to the cholesterol, carrying it out of the liver and just delivering it everywhere, right? ApoA is your pick back up and take it back to recycle it back. If you have a ratio of B to A that's less than 0.6, cardiovascular risk appears to be very low, even when you have an ApoB that's a little bit elevated. So everybody puts a lot of emphasis in lowering ApoB. I actually look a little bit more at that BA ratio when I'm actually looking at treating cardiovascular disease. So I do look at the lipid profile, but I consider a healthy cholesterol 200 to 250. When you look at the data on bigger brains, Dane Goodnow, who presented at our conference we were just at, he has some really nice data showing brain volume versus cholesterol. And there's a very parallel relationship there between brain volume and cholesterol. So we have all these people pushing these cholesterols down to 140, 120. It's ridiculous. And we're doing a lot of harm to those people in terms of muscle growth, in terms of brain. I like to aim for a high cholesterol, a good B to A ratio, and then you've got to reduce inflammation. And that's where so much of our focus is now, is because until LDL gets oxidized, until there's inflammation, so until you have high inflammation, it really probably is not doing much damage, right? So we look at oxidized LDLs, myeloperoxidase, LPPLA2 to look at macrophage activity. Look at all those pieces. And then we focus on treating if there's a lot of oxidative stress. If there's high levels of oxidative LDL, then we're going to treat some of that oxidative stress. If you have high LPPLA2 or high myeloperoxidase, then we're going to go after this from a very inflammatory perspective. I would say most of my patients, I'm addressing much more of this from an anti-inflammatory effect. Now, if ApoB is sky high and you have a high LP(a), I think I have to get more aggressive with those people. I will pull out drugs to do that, PCSK inhibitors sometimes, or bempedoic acid sometimes. Those of you who follow Peter Attia and his ApoB, he's passionate that ApoB should be like as low as possible. And that's actually not true. There's nothing in our nothing in our body that does not have a reason for being there. And ApoB is the same way. And when you look, ApoB actually has some really beneficial effects for infection protection. Remember, we need it to carry this stuff. And so you don't want to drive ApoB super low.
What else do we need ApoB for?
Right. That's from a bacterial infection perspective. If your ApoB is less than 60, you are much more likely to die of a bacterial infection. I think Peter's all proud of his ApoB of 34, and I sit there and listen to him say this, and I'm like, everything in life is a balance, right? There's nothing in us that is all good or all bad. Nothing. Even bad inflammatory cytokines have their place. We need them. So we always have to look at things in that way. And I think that's a problem in medicine. We get this paradigm of, oh, that's a bad thing. Let's just get it as low as possible. Or that's a good thing. Let's get it as high as possible. And when we disrupt homeostasis, we're doing a lot of damage. But when we look at my go-tos in cardiovascular disease, I use colchicine a lot in these people. So colchicine appears to be a very novel and good anti-inflammatory in terms of the cardiovascular and reversing atherosclerotic plaque, right? And for your pericarditis or myocarditis patients.
Yeah. What kind of dosing for colchicine
I usually use 0.6 twice a day. They basically came out with a drug of colchicine at 0.5 twice a day. And then you can spend a whole lot of money and buy the low dose colchicine, or you can buy the cheap colchicine at 0.6 twice a day. And there's no difference. So buy the cheap colchicine at 0.6 and don't support the big pharmaceutical making the 0.5 twice a day. So I use that kind of dose, and you can definitely see reversal of atherosclerosis. But this is another place where penicillin has been shown, at least in an animal model, to reduce atherosclerosis. And then one of my new favorites is using this drug Amlexinox, which I think you heard me talk about in this lecture. It's probably one of my it is an incredible repurposed drug, and it's really good. In an animal model, it reverses atherosclerosis after 8 weeks by as much as 50%. That's dramatic. Penicillin I've been using penicillin a long time for atherosclerosis. You will see atherosclerotic changes. Those of you who think you cannot reverse atherosclerosis, you can. You can it's not what it is and stop progression. It is, you can reverse it. And I see it all the time because now we have, clearly scans that we can do where we can really monitor that what we're doing is really working on people. So it's really nice. We get this very objective look at what we're doing. So we get a clearly scan. We put these people on these drugs for 6 months, a year, and then we retest it. We can see there's reversal of the plaque. And Lexinox is newer to my armamentarium for treating. I've been using it for autoimmune disease a lot. Been using it for weight loss a lot, but it's newer to my armamentarium for treating plaque. But the animal studies are so dramatic. I started putting most of my patients with atherosclerotic plaque or high risk factor.
Pardon the interruption. This episode is brought to you by Transcriptions, makers of precision-dosed, physician-formulated, and pharmaceutical-grade formulas in the form of a buccal troche. For this episode, check out Troz. It's our comprehensive sleep formula, helping you and your patients fall asleep, stay asleep, and wake up feeling rested. If you do wake up in the middle of the night, you will be able to go back to bed because of a long-acting ingredient in there called agarin from the Amanita muscaria mushroom. No, we're not psychedelic here, ladies and gentlemen. At low doses, it's a long-acting GABA agonist. Go to transcriptions.com and save 10% on your order by using code POD10 at checkout. Now back to the show.
They have high myeloperoxidase. They have high LPPLA2. They have a high ApoBA ratio. I've started putting them on, and we'll see. I'll keep you posted on that. But if it pans out as well as you think it is, then it should be helpful. And Lexinox and Peptide are working from two very different mechanisms on that. Peptide's working probably on its effect on the metalloproteinases, like 2 and 9, I think, are the ones that really affect atherosclerotic disease. So it's working on those two pathways, where Lexinox is working what's called tank binding kinase. So they're working on two different pathways. I suspect the two together would do really well. I don't usually do that just because of cost. So I'll usually go with colchicine and Lexinox, or colchicine and penicillin, depending on the patient and what else I'm doing with them. But I am not using aggressive. I rarely use statin drugs, except I'll use statin drugs at a low dose in my cancer patients to stop growth, because that's the one group where probably blocking mTOR and blocking mitochondrial function is a good thing. Otherwise, I don't use those much. I'm going more after the inflammatory piece on these diseases. I think these are inflammatory diseases.
I think that's
like everything. Said.
I think it's beautifully said, because we have at Transcriptions, we have a nonprofit organization called Health Optimization Medicine and Practice. And Dr. Ted, who founded it, he always says this: you need to have a fire to put gasoline on there to make it burn. So if you're working on the inflammatory side of things, and then that's the issue. I'm 100% with you that we are so focused, because of people like Peter and other, on dropping our LDL to 0, that we forget that this is an actual product of lipid metabolism that we need,
and that for everything.
And you have a much higher risk
for muscle, for making vitamins, for making hormones, everything. And I fight with the cardiologists all the time on this, because they really come in with a cholesterol of 120, and the cardiologists are thrilled.
Yeah. And their brain. So I didn't see the lecture on brain volume. Is it significant after a period of time being on these, or what was Dan just looked at brain volume versus cholesterol level, not statin drugs, just cholesterol levels, right? Gotcha. So he just looked at cholesterol levels, and it was just a linear relationship. So they just did cholesterol and functional MRI scans, looking at brain volumes, and just saw a linear relationship: higher cholesterol, higher brain volume; lower cholesterol, lower brain volume. But not specifically statin drugs. We just know that statin drugs are lowering cholesterol. So secondarily, they should fall into that group where they're going to have smaller brain volumes. And not to mention the mitochondrial toxicity, which plays a role there as well. Again, like any drug, I'm not going to say there's never a place for them, but I think you have to think what you're using them for. Yeah. So you mentioned statins you use in cancer patients. You also mentioned the bladder drug we were talking about in the beginning, using for cancer patients. What are some of the other novel therapeutics that you're using? I see a lot of cancer patients that come to me asking about hyperbaric therapy, for example, and I'm always referring them to people like you, Elizabeth, to talk about the main parts of care, because every cancer there's a lot of similarities between cancers. Everybody's going ketogenic these days. I don't know if that's always the case for everybody, if that should be the case, but I have lots of practitioners that do think that. What is your overall approach maybe for a cancer patient? That's a big picture, but I'm sure it's inflammatory to significant degree as well. But what you can delineate there that you think is novel about your approach?
Cancer's tough, right? Because it is the opposite of what we try and do with everybody else. We want super healthy cells, and we want these people to thrive, and we want them to grow and be able to put on muscle. And the hard thing about cancer is you're going to have to kill the patient a little bit to kill the cancer. So we want to block growth. Whereas in you and I, you don't want to completely block mTOR. We want to have this an AMPK. We want this balance. Surge mTOR up so you can build some muscle, but then surge it back down so you can promote longevity by promoting AMPK. It's a tough group because you have to do the things that are not, and that's where, like I said, statin drugs do have their advantage because they are mitochondrial toxins. And so by doing that, you can inhibit cancer cell growth. It's a place where I'll use metformin too. I'm not a big fan of metformin anymore. I was on everything in our world. As we learned more, we thought, oh, metformin, great longevity drug. And they're like, oh, maybe not. It's causing sarcopenia. It's doing other bad things, but it's still a good cancer drug, right? For a couple of reasons. I do think you want to glucose starve the cells to some degree. So I do think a ketogenic diet and exogenous ketones can be super helpful here too, especially if you have somebody who really, it's hard to keep them completely ketogenic. They don't have a great appetite. It's hard to get them eating. You can certainly utilize a combination of being at least somewhat keto and then using exogenous ketones along with those patients too. It depends on the cancer. One of the things cancer cells have to do to metastasize is they have to go from it's called epithelial mesenchymal transition. So a cancer cell can't metastasize until it turns back into a mesenchymal cell, right? So it has to turn back into almost a stem cell, and then it can metastasize and move on. If it can't do that, it won't metastasize. It'll stay in place. And that's where amlexinox blocks the ability of that cell to undergo epithelial mesenchymal transition. So I can block, while I'm trying to kill off the cancer, I can block the cancer from being able to metastasize by keeping them on amlexinox. So it's another place. Also, a lot of cancers, particularly things like lymphomas, are in prostate cancer and breast cancer too, affect what's called the tank binding kinase pathway. So that pathway is very linked to cancer. And a lot of the cancer drugs focus on that pathway. So that's where amlexinox has its biggest gun, is against tank binding kinase pathway. So basically by blocking TBK, I can really, so I use that drug in all my cancer patients, especially as I said in my lecture that you heard, in my watchful waiting patients for prostate cancer, because those guys, they're probably going to die with their prostate cancer if I can keep it from metastasizing. So that's my goal, is to keep it in play.
Right.
I will use ivermectin a lot in cancer patients too. The data, I don't know if you've looked at the data on ivermectin and prostate cancer. It's pretty amazing. And there's a couple other cancers too, breast that's been looked at too, but probably some of the biggest research is ivermectin and prostate cancer. And what you do, interestingly enough, with it is, and it's blocking one spot on cell cycle replication, but what you do with it is you do it for 4 days out of every week. So 4 days out of every week. You think about cancer, I always explain to my patients, cancer is like an army coming at you. So first thing, keep the army from being able to take over other villages. But then we got to start trying to kill off the army. So if I kill off the front line and think, oh, good, cured, no, there's a next line there, right? So what you do with the ivermectin is kill off the first line, wait for the second guys to come up, kill them off, wait second guys to come up. So by using ivermectin on a 4-day on, 3-day process, you seem to be able to really get a hold of that cancer population. And over time, and I've seen reversals in PSA simply with ivermectin, with nothing else, because it's cheap, it's easy. Simply with ivermectin, I've seen PSAs go down 50% in some of my prostate cancer patients. When you add amlexinox in, it can be quite dramatic. And goal would be, again, trying to catch these patients before they've already metastasized. Now, is it still beneficial in metastatic patients? Yeah, of course. But it's always harder to get a cancer under hold. So if we can catch these patients and start treating them aggressively with these approaches. So yeah, I'm using metformin, I'm using statins, sometimes a lot of doxycycline. Doxycycline has some interesting benefits in cancer. More often I'll go with ivermectin, amlexinox. And again, depending on cancer, I may choose penicillin over amlexinox, depending on what type of cancer it is. Penicillin seems to be maybe a little bit better for some of the types of cancers. Amlexinox much better for most cancers, I think, because tank binding kinase pathway is a very influential pathway in almost all autoimmune diseases. Psoriatic arthritis, inflammatory diseases, rheumatoid arthritis, very much, and it's very linked to cancers. It's a really interesting, that's a pathway you guys should all read about and know about, the TBK pathway, because it's a pathway that if you can intervene on, you can make big differences in people's health.
That's amazing. So you mentioned ivermectin, which I love, because people get so scared of that word. And I'm going to bring it up to even scarier combination, which is long COVID, ivermectin, and other drugs, therapies, and things that you found to be helpful. This is a big issue, right? We're seeing maybe, I don't know, my estimation is about 20% of the population that had COVID probably has long COVID symptoms, maybe higher. And it's at least that much, I think, for the vaccinated population too, ish. It would be interested in what you think there. And then what are you doing? I'm guessing a lot of the very similar things that we've already discussed from an inflammatory perspective, but things like ivermectin are being used now for people I know that maybe have constant protein replication
Right.
or
I think you and I probably get a little bit of a warped view of how many people, because I would say everybody in the world has long COVID because I see way too much of it. It's been the bane of my existence since COVID, and COVID vaccines is the number of patients we have who now have completely disrupted immune systems, promoting autoimmune diseases. I've got so many patients with myocarditis I'm treating. It's just frightening to me. So yes, use ivermectin in those patients because there is still a viral piece to it, most of them, right? We know that there's still, particularly in the gut, that there is still active spike protein affecting enterographene cells, which is going to continue to affect the immune system. So ivermectin is a big go-to on those patients.
Across the board, or do you have a delineation of who you're going to give ivermectin to versus who you're not going to give to?
It would be my first go-to on a lot of people. Sometimes it doesn't work, and I'll have to go to something like tenofovir or some other drug. I will sometimes start with Tolavid, which is a natural antiviral that you can get. I'll start there mostly because I have some people who freak out and they're like, they've heard all the bad stuff about ivermectin, and yeah, you can teach them but sometimes, okay, if you're not comfortable with it, let's just start here. Let's see if we make any headway. Tolavid, I think, can be very good for some people. I think ivermectin. So I would say most of my long COVIDs, I'm like, so if I look at long COVID, I'm like, treat the virus that's still there, right? Which you're going to do with some type of antiviral. And to me, ivermectin is probably one of the safer ones and works very well. We know for COVID, there's lots of studies on it. And then you've got to treat, this is a mitochondrial disease. So you've got to treat mitochondria. So that's my next target, is how am I going to help fix the mitochondria? Because mitochondria have been very damaged in long COVID. And that's why the horrible fatigue sets in. So it's get rid of the virus, fix the mitochondria, fix the gut. So you get that brain-gut connection fixed. Try and get the sympathetic nervous system quieted down for all those people who have POTS and everything else along with it. But that's my order. So I'm going to get them on the ivermectin. I'm going to start them on something for mitochondrial function. Usually that's going to include methylene blue. Great. Methylene blue is going to really help that whole redox pathway to accelerate a little bit. So they're going to get more ATP production. But you also have to repair the intermitochondrial membrane. So you'll use a lot of SS31 for that. Mitochondrial peptide that actually can repair intermitochondrial membrane. If they're not quite as sick, we might go with MOD-SC, another mitochondrial peptide that's more mitochondrial biogenesis. So basically, methylene blue, almost everybody. I would say I don't have any patients who are not on methylene blue because it also has antiviral properties, right? It's your magic drug. Everybody's going to be on methylene blue, and then combine that with, if they're really sick, SS31 to try and help heal the mitochondria, and then maybe transition them as they're getting better into MOD-SC, just build back mitochondrial biogenesis, help metabolic function, and then work on gut. We know that the whole damage to the whole tryptophan metabolism system. So you've got to work on fixing that, giving them some tryptophan a lot of times. I'll use a lot of things like vagus nerve stimulation to try and settle down that sympathetic overdrive with those patients. And then you just keep piecemealing it. Some people, boom, you can get them better really nicely, particularly with them. Just, I don't know, you use methylene blue a lot, and you've seen it. Methylene blue can be amazingly wonderful for these patients in and of itself because it covers so many bases.
Sure.
Right?
Yeah, it's got the
antiviral capacity. It's got going to boost up the mitochondrial function. They're going to feel more energy. So it's hitting with from a lot of pieces with almost no risk factors. So I always say no risk factors, and then somebody always comes back to me on these podcasts and says, "There's nothing without risk factors." And of course, that's true. There's nothing without some.
Yes, and of course that's going to be the comeback. A question about tryptophan metabolism. I don't know about that piece. What's going on there?
So basically, because of the damage to enterographene cells, we know that there's downregulation of the tryptophan receptors. And so basically you can't make serotonin very well. So that's why they get this depression and anxiety, is this low serotonin. So you have to flood the system for a while with tryptophan. So basically we'll use a high dose, like 1,500 milligrams of tryptophan for a while, along with a lot of cofactors. You need to make sure they've got methylfolate, they've got zinc, they've got D on board, all those other cofactors along with that. You'll have to do that for a while to try and flood the receptors to try and get serotonin metabolism back up for the brain, because these people are so depressed and so anxious. And that's why, is because they are not metabolizing tryptophan well anymore. And you have to use high dose. You got to use 1,500 milligrams at least for a little while. But lots of times when you do that, you'll see rapidly their mood improves, their anxiety improves rapidly within 2 weeks. And then we can drop down the tryptophan to 500 milligrams twice a day. So you'll start with 500 milligrams 3 times a day for a while, flood those receptors, try and get serotonin levels back up a little bit, again, giving them all the cofactors, and then you can drop them down for a while. But tryptophan metabolism is one of the big things that gets disrupted in these patients. And it has to do with
I
the
didn't
spike
realize that.
protein actually
Yeah.
still infecting the endographene cell. So again, treat the spike protein too.
Yeah, so we have some good data out there that the spike protein can infect the cells in the gut and
Right,
maintain there
exactly.
for a while.
Yeah, it
Gotcha.
seems to be one of its
And,
places it seems to sit.
and is this both in the vaccinated
Yeah, there's no
population
difference whether you got
along with
vaccinated and had a big load of spike protein. Well, I don't know. I have opinions on which is worse, but either way, you're getting a
you leave those
load
to
of
yourself.
spike protein.
Yeah,
So neither
yeah,
and I will say I have equally as many vax injured people as I have long COVID injured people from getting COVID. It's either way.
yeah. Do you find it's more difficult to help or to improve symptoms in one patient population than the
Yeah, I
other,
will say
or is it
I think the
about the
vax
same?
injured people are tougher, especially I think that
Yeah,
they're a
that's been
tougher
my
group. Yeah.
experience. Yeah,
I think they're
yeah.
probably have
Definitely use
higher loads.
hypertrophy
They're probably still manufacturing a lot more spike protein. I think they're harder to treat, especially then when they
yeah,
get COVID.
yeah. I definitely used hyperbaric therapy.
And a lot of these people too,
Yeah,
you get them better and they get hit with COVID again, and you got to revamp things a little bit. But you got to focus on mitochondria in this disease. That's why there's so much fatigue. It is really a mitochondrial disease. All the other pieces play a role, but you've got to focus on mitochondria, and that's where peptides become so helpful to us, because there's not a lot of ways to fix mitochondria, and so we have to go with the endogenous mitochondrial peptides, which are humanin, SS31, MADA-C. Those are all our peptides that our mitochondria are supposed to make when they're stressed. And if they're not making them appropriately anymore because we damaged them too much, or we just don't have enough mitochondria left, then we can't get better. Our energy levels I got really down and out from COVID. I got it very early on, but I was sick as a dog. Like 2 weeks, I felt like I could not get out of bed. And it probably took me 6 months to feel like I could go back to doing things. And I would say even now, and I've done a lot, my endurance is never where it was before. So I don't know. Can we get these people back 100%? I don't know. I would hope so. But it's a tough disease. But so is we put all this emphasis on COVID, but so is Epstein-Barr, right? We just sort of ignored Epstein-Barr and all the chronic fatigue syndrome people, but it was the same disease. We just said you people are all crazy, instead of actually now so many people have it, we can't deny it anymore. But with the EBV and the chronic fatigue syndrome, it was the same. It's the same problem. It was the same disease. It was still active virus and mitochondrial damage. We just poo-pooed all those people for a long time. So I feel happy for those people, at least, that now they have some justification that truly they were not. They're not just crazy people.
We can treat them
because they got a lot of that, right?
Yeah, we can treat
all
them
the
too.
Chronic
right?
fatigue people are like,
I've
you're
actually
just depressed and mentally unstable.
Yeah, no, I got a lot of that from people that have had chronic illness for a long time, that they're being looked at as real.
It's interesting, right? That this diet, because now so many people got it that it was like, okay, we can't deny this is a real entity anymore.
Yeah, I had a question actually, Elizabeth, for mitochondrial function testing. There are a couple tests out there that purport that they can actually diagnose the complex disorder by a swab or something like that. Do you believe in that stuff? Or
I don't know what your opinion is of it. I've gotten very variable results. Guys like, great, this is wonderful. Let's. I don't think so. I don't think you can do that very realistically. The mitochondria are complex. What you're going to be able to find in serum is not going to be related to what's going on inside the inner mitochondrial membrane, where all this stuff is going on, right? I will make some, when you look at like a prodrome scan, Dr. Dana's prodrome scan, he puts some pieces together that I think is probably our best way of looking at if there's mitochondrial dysfunction. Okay. But I think a lot of it has to be somewhat just what is going on? This person has horrendous fatigue. They can't do anything anymore. There's something wrong with their mitochondria, right? Their metabolism's all screwed up now. There's something obviously wrong with their mitochondria. I don't know that I need a very specific test to tell me, and if it comes out normal, what does that mean? Because obviously the patient's not normal. And I'm like that. I'm not I do testing on my patients. I look at nutrient function. I'm looking at hormones. I'm looking at thyroid. I'm looking at complex cardiometabolic. I'm not a big fan of doing all these big fancy tests on people. I think that people are doing all these neurotransmitter tests. You can't really tell what's going on in the brain, right? If I'm measuring neurotransmitter metabolites in your serum, there's a big blood-brain barrier here that has nothing to do with what's going on in your serum. And people come to with these massive tests, especially now. There's all these companies that are popping up that are just offering patients tons of tests. I have people coming to me with literally a notebook full of tests, and they're like, "What do I do with all this?" I'm like, "I don't know. What are your symptoms?
Clinically, what are you doing?"
What do you feel like?
I know. Yeah, that's the thing. I have these conversations with patients all the time. Your neurotransmitters are not.
Yeah, they're not. People hang their hat on this, right? I'm like, how's that do? Why? How does that have anything to do with what's going on in my brain? The blood-brain barrier is very particular about what's going on. You can't measure your metabolism.
Yeah.
People are spending $800 on these tests, and I'm going to base that on, okay, you're depressed and miserable. Probably we need to get your serotonin up a little higher. It's
Yeah. Speaking of the brain, I wanted to go there a little bit too. So as far as I see a lot of brain injury, I know I see a lot of brain injury and stroke.
Sure, with your HBOT, right?
What are some of the novel therapeutics that you're using here? Maybe that's been used for a while, but like other docs would really not know were even choices for these kinds of patients.
There's so many cool things you can do with brain, and it makes me sad because we usually get the patients. I don't know how acutely you're getting them, hopefully more acutely than we are. Yeah. If we could get these patients like right after their brain injuries, right? We could do so much, but we had this guy, super high level cyclist, incredible guy, ran a big company, got hit by a truck on his bike. And by the time we saw him, he'd been through and bad brain injury, bad wheelchair bound, can't do anything for himself, can't feed himself, can't. So he's in the acute stage for a while, and then he gets put into Craig rehab for 6 months, and then he's out doing whatever. And then we see him a year and a half later. And can we still do stuff? I hope, but it's certainly not as good as if we could have caught him early on. But nobody's referring, like Craig rehab should be talking to us, right? I don't know, does Craig do any HBOT? Do they? Yeah, that'd be a simple thing, right? To put into the rehab hospital. But there's so much you can do for brain. And so the more acutely you can treat, even those of you who have a concussion, there's so many things you can do. HBOT, obviously wonderful, right? Benign, wonderful, hugely beneficial. And we know the studies on that. But what can we do from a more medical perspective on using peptides and drugs? That's where I think peptides have huge benefits. So if we look at peptides for brain, one of our go-to is cerebrolysine, around for 25 years in Austria, widely used in Asia. So if you have a stroke, you have a brain injury, first thing they're going to do when you get into hospital, start running IV cerebrolysine, 50 mils a day. Here, nobody knows about it, but marked difference in people's recovery if they had cerebrolysine early on. Now, we get them later down the road, but we still see significant benefits. We had a patient, young kid, who was riding the back of a pickup truck at school in Montana, and pickup truck stops short. He falls out, horrible brain injury. And he'd gotten somewhat better, but couldn't really take care of himself. He could walk and he could talk and he could eat, but he's not going to be independently functional. And he's young, so that was nice because young people heal better, but he was 18. But really after probably did about 8 rounds of cerebrolysine, he was starting to work again, actually going to plan on going back to school in the fall. I mean, it was dramatic. So basically cerebrolysine is a peptide so actually a conglomerate of peptides. So it's really made from pig brains, and pig brains are utilized because pigs don't get prion disease. Unlike cows, pigs don't get prion disease. So basically it's just a bunch of peptides taken from pig brains. And the reasons it will never get to the US, so we very well know the company who makes this is called Everpharma in Austria. We've been there. We know them very well. In fact, the only way we used to be able to get cerebrolysine is we would fly to Austria, we'd fill a suitcase with it and bring it back because we could not get it across the border. So it was amazing, guys. You could not get this drug across the border, like mailing it. We would literally go there with a giant suitcase and it would get here no problem. I mean, basically, cerebrolysine IV infusion, dramatic improvement in people's symptoms. And what we do is have them come in for a week. We do a dose every day for 4 days. We're trying to, as much as possible, have them come back a month later. Sometimes when people live far away, that's hard. If they're close by, we can do it even more frequently. But really dramatically, but also really good for dementia. So that's one of the other big places they use it for in Austria and Asia is for cognitive decline and Alzheimer's. And there's tons of data on this drug. If you Google cerebrolysine and brain injury or cerebrolysine, there's a lot of data. Like I said, this drug's been around a long time and used in every hospital in Austria and Asia. So why aren't we using it? To try and get it across our FDA, because it is a group of peptides, you would have to get every one of those peptides authorized for whatever specific purpose, like for traumatic brain injury and then for dementia. And so talking to Everpharma, they're like, it's not worth our time. We are a hugely profitable company in what we're doing. Why would we spend millions of dollars trying to get this through the US? So it's sad.
Right.
But there's other peptides that are really good for brain function too. C-Lank and C-Max are both peptides that came out of Dr. Kavinson's lab in Russia. And C-Lank is really neuroprotective, it's anti-inflammatory. So it's really good for you. We know that neuroinflammation, particularly shortly after brain injury, is one of the big things that causes the secondary injury. So if you can use C-Lank, it's a nasal spray. So nasal sprays are great, right? Because they get right to the brain. So if we can use a nasal spray of C, we can get significant reduction in inflammatory changes. And then Cmax is used to perk back up neurons to cause more new neural connections to form. So in the early anti-inflammatory stages, you'll use the C-Link and then you'll add on Cmax as they get better to try and get more neural connections going. And then lastly, dihexa, which is being looked at primarily in Parkinson's here in the US. So studies are going on right now for Parkinson's because it seems to be really good in the Parkinson's population, but it is good for other people too. It improves BDNF just like all the peptides do, but it has some other really important functions as part of what's called hepatic growth factor that basically improve neural function, particularly in the Parkinson's group. And that's a peptide that can be done as an oral peptide. So that's nice because most of the peptides have to be done injectable. All the nasal sprays are pretty easy, even in your dementia population. C-Link and Cmax are both going to be harder to get with some of the newer bans on peptides, a little more difficult for us to get those. Dihexa, it's not on the FDA bad list. So you can still get dihexacerebrolysin. We can still get. So those are really, and it makes me really sad because you can do so much with these peptides. And then right now we're involved in a study for Alzheimer's using a drug called TB006. Have you heard about this at all? So TB006 is a galectin-3 inhibitor. So if you look at galectin-3 is elevated if this drug gets approved, it'll be cool because we can use it for a whole lot of other things. Galectin-3 is elevated in cancers. It's involved in most degenerative diseases, but very elevated in Alzheimer's patients and other cognitive decline patients. So if you can block galectin-3, so TB006 is an antibody to galectin-3. Again, this will be very cool. I'll just take it prophylactically because galectin-3 elevations, it's pretty rare you will see somebody with a bad disease that does not have high galectin-3. So I actually think this drug can have benefits for our autoimmune people, for our cancer patients, things like that. But it's in trials for dementia. And it's an IV infusion that you do once a month, basically. But the results have been astounding. We've only done a few patients, but some of the centers have been doing it for a while. I think it's about 30 centers in the U.S. that are doing it. Some of the centers that have been doing it for a while have some videos. Patients, this one guy who was literally sitting there didn't even know who his daughter was, sitting next to her. They asked who she was. He said he couldn't remember, he couldn't place her. And then after 3 infusions later, so 3 months later, interviewing him, and he's talking very fluently. He well knows who she is. He said, I'm going to see if I can start driving short distances. It was that dramatic of a difference. So we're really excited about this drug. We'll see how it pans out, but it's super exciting. I think it's super exciting for a whole lot of purposes. I'm trying to just see if I can get some to use for other things. But right now you have to fall into the criteria of having dementia. Even mild dementia qualifies, but nobody is too far gone. I will say so far, I think I'm seeing better results in my people, as you would probably expect, but in my people who are not as far along that path.
Sure.
The hard thing is because it's a study, you're not supposed to be on other things. And my bias is there's not going to be one drug that's going to be the cure. These people need plasmalogens and they need and they probably need some of the peptides like dihexa, or there's another one called FG loop peptide that's actually also really good for dementia. And so I have this little bit of a moral dilemma on, okay, do I just follow the protocols and give them the TB006, or on the side, do I give them these other things too? And especially if they've been on these other things already. So I know what their baseline is on these other things. I still feel like I can get good data from TB06. But I'm excited
like the dirty little
it.
secret with all this. The dirty little secret with all this stuff is that you're adding drugs to regimens that are already in place.
Right.
And then these studies are leaving things in or out. And it's a bit of a tricky thing.
It's tricky, right.
But what I want to talk about before we finish though is one more thing, because it's controversial. It's NAD. So, you and I have heard and know many people that have clinics that give IV NAD infusions and NAD supplements and NAD suppositories probably. What's your overall 33,000 foot view on NAD supplementation, IVs and things, and where do you think people might be getting into trouble?
So I'm going to piss off a lot of people because here's, just like I said, there's nothing that is not there for a reason. And you can't just say, oh, as we age, NAD gets lower. If I put NAD back in, I've made that patient better. So that's what people do. They measure NAD. Whether you can actually measure NAD is very controversial. People can tell me they can measure NAD, NADH ratios. It's inside the mitochondria. Again, you really can't get a sense. It's very different. Cytoplasmic and mitochondrial levels of NAD are very different. So you really can't get much from an NAD and NADH level. So number one, I'm skeptical about the testing. Number two, so yes, you might have lower levels. Is it bad to have lower levels? Yes. You have to look at why are your levels lower. The reason your levels get lower as you age is primarily because of the enzymes that are degrading them. And there's two enzymes, CD38 and one called NNMT. The big bad player there, for the most part, is NNMT. So NNMT is very upregulated in bad cells, senescent cells, fat cells, cancer cells, right? You're putting NAD into a system. The way your body gets rid of excess NAD is by turning up NNMT primarily in these cells. And where NNMT is the most utilized is in these bad cells. So these bad cells are saying, oh, great, he has all this extra NAD. I'm going to use that to grow and thrive. So you're just taking this, it's like filling a water bucket with a hole in it, and the hole's feeding water to a dragon, and you're going, this is great. Look, my bucket's full, all's well. Meanwhile, the dragon's growing. So what we really advocate, that's if you're going to do NAD, fine, got to block the enzymes as well. My feeling is the mouse state support, we actually don't make less NAD, we just lose more, so block the drains. So you can use apigenin to block CD38. What we really like is an NNMT blocker. And there's only one. There's one that's a peptide called 5-amino-1-MQ, but there's another one called 1-methylnicotinic acid, or 1-MNA. So 1-MNA comes from Eastern Europe, just got available here in the U.S. It was very hard to get it here in the U.S., but is available now. So 1-MNA. And if you guys want to learn more about it, go to, I guess it's 1mna.com maybe. But basically, if you can block this enzyme, Google NNMT and every disease you can think of. NMT is upregulated in everything bad. If I feed NAD into a system, I am upregulating an enzyme that is bad in every disease. Unquestionably, you are elevating it when you give NAD, unless you give the perfect amount of NAD. But we have no idea what the perfect amount of NAD is. So instead, let's block NNMT, because NMT blockers are being explored for cancer, for obesity, for cardiovascular disease. So if we can block NMT, we should self-regulate NAD, right? And so by giving this 1-MNA, it blocks NNMT. Now, 1-MNA is also the byproduct of NNMT, but interestingly enough, it will then spill off into what's called a 2,4-pyridones, very linked to bad things. That's why niacin was linked to cardiovascular disease. When you give too much of it, it's because of 4-pyridone, which is when it's metabolized. So it's a very interesting mechanism. All I wanted to say is that you got to be, when I talk about jumping on bandwagons, I always go back to radon. Those of you guys who read the book about the radon girls, can't remember the title of it, but the watchmakers, these little women who painted faces on the watches in radon so that they would glow, the watch faces would glow for the soldiers to be able to see. Then all these women started glowing, and they were considered like, wow, this is like magical. And so they thought radon was a really good thing. These women are glowing. And a little bit of radiation did actually cure disease, right? We can treat cancer with it. But what happens? Too much radiation. So then it's all these women who had been the watch painters started developing these horrific diseases, right? Like horrific diseases. But it took about 4 years before they made the connection between this high dose radon. They had, it's an interesting story because you could go drink radon water and you could go to radon pools, and they made radon underwear. Everything was radon, just like we're doing with NAD, right? Wow, this is a really good thing. Look at how good it is. Radon makes people actually glow. It's so amazing. And what are we doing when we look at these things? So yeah, maybe a little bit of NAD is good. How do you know what the right amount is? We don't. And the body is so necessary to be in homeostasis. When you screw up that redox homeostasis, when I put too much NAD and I screw up redox, I'm screwing things up.
Elizabeth, this has been a great conversation. Thanks so much for being here. I want to ask you one final question that I ask all guests at the end of the podcast, which is, like, you're a wealth of information. Obviously, you do a lot of things yourself. This has been a fantastic conversation. What are the 3 things that anybody can do that are relatively simple to live smarter, not harder, in their world and the world around them?
I'm sure you get the same answer to this question every time, which is basically sleep, exercise, and don't eat shit.
Good. Those are good.
Give me one. Those are the 3 things that we can all do that are going to be paramount to our lives. But I'm going to add the biggest thing that we all forget, and I think that is so problematic anymore, is that a bigger predictor of your health span than anything else, number one on any of those lists, beyond sleep, beyond exercise, beyond every supplement that we talked about, is actually socialization. If you look on the scale of, we give our patients a little quiz. Do you feel valued? Do you have people that you hang out with every day? Do you hang out with people of other ages, right? That's actually really important. It's funny, my parents lived in their 90s, but I'll attribute some of that to the fact that they took care of my kids, right? So they were around different age kids through their whole life. And And we don't do that, right? As you get older, you are with your older crowd. You're not around little kids anymore. So you need to be a multi-generational people. You need to be around people. You need to be, interestingly enough, you need to be productive. And very interestingly, you have to be paid in some way to actually, so it doesn't have to be monetary payment, but something. So people are like, I volunteer my time. Then there should be some reimbursement for your volunteer. They're giving you some little gifts or doing something. It was very interesting, that factor. So I'm a big advocate of don't retire. People need to keep being productive. They need to keep doing things. They need to keep working. They need to keep their mind stimulated. I think that gets ignored a little bit. We get into this, I can't wait till I'm retired. I'm like, I'm never going to retire, but I'd like to have more time. But I'd like to work a little less and have more time to travel. Yeah, but I'm not going to retire. And so I think that's a big thing people have to look at is, are you a productive member of the society? I don't care what it is. Are you hanging out with people of their ages? Are you interacting? I think we really ignore that. As physicians, we don't really talk about that with our patients. Are you lonely?
No, I love it. I think that's a great way to end. Elizabeth, where can people find more about you and the work that you're doing?
So basically, Boulder Longevity Institute, or BLI.com, boulderlongevity.com. We also have a learning academy. It's called Human Optimization Academy. It's very cool. We have a lot of doctors on it. We have just people who love, but they're really smart people. And we actually do a Q&A session every month that blows my mind, because people ask questions that are just out of this world. So that's at bli.academy. You can join that academy. There's a lot of content on it, but these Q&A sessions are worth it in of itself, because I can't tell you the questions people ask that are just amazing. We talk also about different peptides, all these different drugs. So really wonderful. You can follow me at Dr. or at Boulder Longevity Institute. And then, but look at our bli.academy. It's very cool. Those of you guys who want to learn more about some of these drugs, we also have a glossary. You can go to bliglossary.com, where you can learn about amlexinox or telmisartan, or drugs that we use in these different purposes. So that glossary is designed for our patients or anybody who wants to be able to look at data, look at stuff on there. But if you go to Boulder Longevity Institute or just boulderlongevity.com, then that can connect you to all those other sites.
It's amazing. Thanks so much for being here, Elizabeth. I'm glad to have you as a neighbor and a colleague, and pushing the envelope in so many ways, and being controversial. No, being controversial and not doing things your way. Until next time, thanks so much for being here again.